Hi, this is Joe Mullings with The Other Side. Today we're with Barbara McLean, who's a critical care clinical specialist at Grady Health and down in Georgia, Atlanta, correct?
Yes,
And thank you for joining us. You reminded me as we got on the air that you are there, right there in the hospital right now.
I am. Yes.
And thanks for taking time. I don't want to keep you too long away from continuing to provide care to those in need. Bring me up to speed. You're in Atlanta. What's going
I'm
on
in
down there
Atlanta.
right now?
Well, I can really speak I can speak in general about Atlanta that many of the hospitals around us are very overwhelmed. They have many COVID-19 patients. I'm in a public hospital. I'm at Grady Hospital, which is slated for 985 beds. We are not operating at that level right now because we had a massive flood in December and we lost 250 of our beds. So that's put us at a little bit of a disadvantage. We traditionally see about 220, 250 patients a year in our ECC. And we're a hospital that provides care to anybody, regardless of their ability to pay and regardless of their status. And I think we are in a little bit of a quiet period. We have a couple of units that are filled with COVID-19 patients, a couple of intensive care units, a couple of floor units, and we are preparing for what we believe is going to come next for us. Some of the other hospitals in Atlanta, I think that they've had a much more rapid incline. Ours has been a little bit slower, even though to the providers it doesn't really feel that way. But in the bigger system look, and in the Atlanta look, it may be because we're so well prepared that we are not feeling that overwhelmed as a system. Now, again, I want to make sure you appreciate the individuals who are taking care of patients feel entirely overwhelmed.
I'm sure. And you had mentioned we were prepared. Define that for me, being prepared, because that's the first time I've heard this from any healthcare provider, whether it's PPE, whether it's ventilators, whether it's beds. So how did you prepare yourself so well?
Well, I don't necessarily think we prepared ourselves so well for the coronavirus and for this very disastrous enemy, but we have a really good emergency plan. We certainly were one of the level 1 hospitals that was set to take Ebola patients. We had a lot of training that was associated with that. We have this really good, effective disaster response. So I should be very cautious in how I said that. So let me restate it. You can never prepare enough for a disaster, and you're never fully prepared when a disaster hits. But we have always been in preparation for disaster. So when I say I feel like we were prepared, that's really what I meant. I also think that our administrative teams, our supply chain teams were very cognizant of what was to come. And I think that they gathered supplies early on, and they also restricted our supplies early on in order to try to assure that at the most effective level, we would always have what we needed as we move forward. We've had to be very flexible, very MacGyver-like, making adaptations. And typically, what I would say I'm very proud of is that I feel like in my institution, looking at especially for the supply chain folks, that they are working so hard to try to assure we have some basics of what we need. That does not mean that we are not, just like everyone else, concerned about our supplies, having to adapt quickly, having to use things that we would not normally do, keeping our N95s longer, of course, than normal, keeping them fairly long, thinking about our face shields, thinking about our goggles. So I don't wish to misconstrue that.
Mm-hmm.
I just want to make sure that I give a shout out to this team that is working so diligently trying to adapt to scarcity of items and trying to find alternative ways to provide us with what we need.
You mentioned earlier that you had gone through some training and preparation on the Ebola side of things, Barbara. What did you learn from that that may be an advantage now, maybe an organization that did not go through that previously and is getting their first taste of this through the COVID situation?
So what I would just tell you clearly is that my supervisor at the time, who was the vice president of critical care, her name was Kay Kennedy, charged me with being the clinical lead of the hazardous infectious disease unit, which most people would call the Ebola unit. We had a small unit, and I developed a very robust small team of about 16 nurses that came from emergency room and critical care, and we trained very aggressively and very diligently for management of Ebola. Now we were fortunate in that we did not have any patients who actually were confirmed Ebola, but we did have 5 patients that we suspected, and I had this fabulous team that we worked really beautifully together. We did a lot of teamwork together. We've maintained our contact with each other, even though in the last year or so we've had reduced meetings for actual training. However, we have done a lot of work with a program called the EpiPeach trial, where they evaluated our process. They tried to build ICUs based on, or build Ebola units and containment units based on what we were doing. We got a lot of kudos from those groups, and we kept really tight as a group. So when the first patient came to the hospital, the first PUI patient, I myself plus another nurse from my team actually provided care for that patient in conjunction with a nurse who was not on the team, but who was willing to be trained, and actually an infectious disease provider. So the 4 of us actually took care of this patient for 6 days, and that really kind of renewed our spirit. And what we realized at that time was that we were going to really need to do some real-time right now education, particularly in PPE. So I think one of the things I would say to everyone who's getting prepared is you need to upload all of your staff. That's respiratory therapists, nurses, physicians, PT, anybody who might be coming into contact or coming into that room. You need to upload them to a singular, standardized methodology of putting on their PPE and taking that off. That's called DON, D with an on, and DOFF, D with an off. And you need to be training people very much so before this process hits. Now, what we actually did is our process hit. We really hadn't been thinking about it. The process hit, and I had a small group, a team of 4 people that were on my hazardous infectious disease team. We already knew we worked well together. They already knew how to do PPE in the highest standard. So shifting to a different standard, which is still a high standard, but a different standard, was pretty easy for them. And between the 4 of us, we were here at the change of shift or thereabouts for every unit that was accepting patients who were under investigation or who were COVID positive. And yesterday we signed over, we need help because it was the 4 of us, and we've been doing it for just about 28 days. And we've been training lots and lots of experts. So we have lots of people in the units, and we knew we had really done a good job, I think, when we would come to a unit where they would have patients under investigation, COVID positive, and we'd say, can we help you with Don and Dolph? And do you have any questions? And they go, no, we're really good. Once we heard that, we felt like we had done a really excellent job. And we trained over 1,600 employees. That would be between nurses, physician, RTs, PTs, radiology, laboratory personnel, and just about anybody who asked, we would train. And
Barbara,
we did that real time right now. So not in your auditorium or in a classroom, but on the units where we were training people because they were getting ready to go in a room, and everybody would be together 3 feet apart. They'd be observing 1 or 2 people that we would dress, and then we would undress in terms of PPE, of course. Mm-hmm. And I think that was a process that was very helpful. And again, I really appreciate my system, because when I went to them and said, we can do this, and these nurses, I'm not going to pull them out of their standard care. These nurses are volunteering to do it after shift and on their days off. My system really supported that. And I think they valued I think they valued highly, highly, highly the job that was done by this gang of 4. That's what we call ourselves now. And I think that in terms of understanding that everyone feels fearful, and that there's a lot of panic and anxiety when all of a sudden you're taking one of these patients, because you're Obviously, the virus is very, very transmittable. It's voracious. It's frightening. And there's a lot of panic and anxiety. And I think having information, so that information that comes from leaderships, that comes from experts who can help you to understand what the virus is, how do you contain it your best way, how do you control your own transmission. And of course, at the end, my always saying to everyone, I just came from doing a big training on one of the floors, was always reminding them that the devil you know is better than the devil you don't know. And when you're going into a room of a person that you know is under investigation, you're treating them like they're positive, and you have the best coverage possible at that time with the best training possible at that time to actually go into that room, that you're probably more protected than when you have to go to the grocery store. And we all know that that's true.
Barbara, a couple questions for you in order here. You use the word investigation on COVID. So let's be realistic here. Patient comes in, and you rarely see these patients. Patient comes in, clearly is exhibiting the signs of being COVID positive. I have heard from a number of first-line responders said they don't seem to test them when they come in. The medical staff are waiting to test them, and actually they're doing a different panel of testing called rapid fire. It's a standard broad respiratory panel to see if they're potential COVID patients. Why would that be happening instead of straight out confirming they're COVID?
So I love the questions you asked, and I'm going to answer them to the best of my ability. So I'm going to ask forgiveness from my ID and epidemiology colleagues. So what I would tell you is we talk about persons under investigation. Persons under investigations, from a Grady terminology and the way we use it, which I really appreciate, is we think you're COVID positive. We're going to treat you like you're COVID positive. We're going to wear our PPE like you're COVID positive, and we're going to send your test. So there are many varieties of testing. The one I'm most familiar with at this moment, that doesn't mean it's going to be different tomorrow, is that we are doing our own Grady test that was vetted and supported and has been approved by, I'm assuming, by the CDC. That typically takes 24 to 48 hours. So you come in, we're suspicious, we make you a person under investigation. And that's where you stay until we have a confirmed positive or a confirmed negative. And at this time, we're still able to do that, and we're doing that really well. If you are confirmed negative, but there is no alternative diagnosis for your symptoms that we can validate or feel sure about, and that's a decision between the treatment team and the ID team, we will continue to treat you like you're positive until we get a CDC confirmational test.
Got it.
So sometimes that means you are 5, 6, 7, 8 days under investigation. We still have concern that you might be positive, even though your prelim test was negative, because we can't find another diagnosis. And I have to tell you something. In understanding and knowing what other systems are doing and hearing what other folks are doing, I'm so grateful for this, because I think in my system, typically we don't release the patient release them from investigation or from our precautions until we really feel clear, as clear as we possibly can. I mean, there's no absolute certainty, but as clear as possible that you actually don't have COVID-19.
Got it.
And that creates a little bit of disarray at the bedside, because it's like, well, the test was negative. Why are they still under precaution? Well, if you come in and you're short of breath, you've got some chest discomfort, you're hyperemic, and you're tachycardic, and you're tachypneic, and your chest x-ray looks whited out, but you have a history of congestive failure, we give you Lasix, your chest x-ray improves, and you have a negative test, we think we have an alternative diagnosis. We're probably going to clear you. And again, that's a discussion between infectious disease and the treatment team.
Gotcha.
But if they say there isn't really a good reason for them to be looking this way, we don't have an alternative diagnosis, we're going to keep you under investigation. So sometimes the staff gets a little bit confused about it. And again, that's where I would go back and say, having really clear, transparent daily communication. And unfortunately, I would tell you that for most staff who are working now, who are donning and doffing and going into 3 and 4 and 5 different rooms, it's really important to remind everyone that the physical work of nursing in particular is now profoundly tripled in terms of physical action with getting dressed and donned and doffed in PPE where you're really hot. And so by the time they go home, which might be an hour or two later than their normal shift ends, they're so exhausted, they are not reading their Grady email or whatever email in order to understand what might be happening. So one of the structures, and they're again doing a really great job at trying to create that, is to assure that there is communication every day with the leaders on the unit so that the leaders on the unit can communicate to the staff and trying to create that really nice communication bond. It's a struggle, however, because everything is changing all the time.
Sure. Barbara, question for you. You mentioned this a few times, you know, the caregivers, the nurses, the infectious disease
all
people.
the caregivers.
All the caregivers. Are you being tested every day that you leave?
No, we are not.
What are your thoughts on that?
Well, again, you know, I'm not an epidemiologist or an infectious disease specialist, but I have worked disasters all over the world. I've worked a lot in resource poor environments. So I'm very grateful for the resources that I have here, even when they're scarce. I'm very grateful for
But
that.
should caregivers be tested when they leave so they don't take it home or they don't infect other patients who may or may not be positive?
Well, I'm coming to that. Okay. So I am also recognizing that at this moment, we still have a scarcity of testing at this moment. And at this moment, what we're doing is if you have concerns, of course, we're asking you to self-monitor, to monitor your temperature in the morning, monitor your temperature at night. But at this moment, we are not being tested. In the best of all circumstance, in the richest of all world, and with no scarcity, would I like us to all be tested? Yes, but that is not the world in which we're in right now. And I understand what you're saying. I appreciate what you're saying, but I think what we want to remind ourselves is that if we're sneezing or coughing and you are working, you should always have a blue cone or a surgical mask when you go into a patient's room who's not a PUI. And we always wear an N95 into the room of a patient who's a PUI.
Right, but you're wearing that N95 so you don't transmit or take in?
Both. I mean, the N95 protects us from you and protects you from me. But I'll wear a blue cone mask to protect you from me if I'm not wearing an N95. So I do think we're doing the best that we can. I think it is really important and for all listeners. So I'm not sure if the listeners are clinical or otherwise, but I think always really important to remember that we're being as cautious as we possibly can, understanding that what we know right this minute is the virus is spread by droplets, which of course are spread with coughing, sneezing, and other procedures that actually aerosolize. So that means if we're giving you a nebulizer treatment, which might be a common thing you did, that's nebulized. Certain forms of respiratory therapy are nebulized. When we place a tube, it's nebulized. When we do a bronch, it's nebulized. Most of the rest of the time, it's droplets. And then droplets land on the surface, and that's contact. So one of our biggest strategies is protect from droplets and always protect from contact on your hands in a non-PUI room. And in a PUI room, we're protecting from contact with our gown and our gloves.
What's changed over the last 2 weeks when you look at these clusters like New York City and Seattle, that the number of cases are just overwhelming? Are we collecting data? Is that changing protocol on a day-to-day period? Has there been any large protocol changes that caught you by surprise that you did not see coming?
I would say probably with a relatively good understanding, as best I can have, of the parenchymal damage and the development of interstitial edema. I think everything that we've done, I would have expected, and that would be very high ventilatory strategies to open the lung. And also to actually put patients in a prone position, stomach down, which is not that usual in the hospital for a general process. In those ways, I think those protocols and those guidelines, I think, were easy to anticipate. I think the hardest guidelines and the biggest changes that are the hardest for us at the bedside, because we here, especially at Grady, we go with evidence and we go with the flow and we step up to a challenge, whatever that is. The hardest challenge for us is having patients be isolated from their family, and especially for us, because we do see patients who are critical, and we are seeing a significant increase in death, and recognizing that our patients are not able to have anybody visit with them or be with them, and then taking that on as well to be the person who is comforting them, with them, holding their hand, holding a phone in a biohazard bag. This is I think now is like my big statement, is that I take a phone in a biohazard bag into the room and hold it to the patient's ear. And the patient is unconscious and intubated, but the family can talk to them. But that is an incredibly distressing, it's a distressing image for you and for the public, and it's very distressing for us as providers. We are not used to separating people, especially in the moment of such severe suffering and possibly the end of their life. We are not used to separating families. In fact, even though we have some strategic guidelines about visitation, at end of life, we let everybody come in the room. Everybody that belongs to that person.
I had a friend, a very dear friend who lives up in New York City. His wife and he caught it last week, and on Friday she became very symptomatic, struggled, he took her to Lenox Hill, and he had to drop her off in a car out front because they wouldn't even let him out of the car. And then she had to walk in through the ambulance center and be sequestered from everybody. And I asked him, 2 days later, how is he? And she's like, I don't know. Is there any mechanism involved on how to connect with people? Is that underway? What can we do to help that?
Okay, so here's what we did here. So on the first patient that was clearly towards the end of their life, we were going to prone the patient. We were concerned that proning might be deleterious because, of course, it can make you quite unstable. It did not in this case, but we had some communication with the family, and there was some discussion because in my hospital right now, we actually do say that outside of COVID-19, if you're in end of life and some other circumstance, if you have behavioral problems and your caregiver is the only person who can help you, that those individuals can come into the hospital. They're screened, but they can come in. But for COVID-19 patients, we have no visitation. So we had a lot of discussion because it was the end of life. And I said, I really appreciate that we're discussing that no family can come, but I can take a phone into the room and have the family communicate with their loved one. And if I had an iPad, I could actually do FaceTime, although I think that would be very distressing. It requires a lot of explanation. So we were very fortunate. One of our great colleagues who was just walking by said, here, I have a Grady phone. I don't need it right now. It's an iPhone. You can use it and take it in the room. So I took it into a biohazard bag, called the family, talked to them. They already knew that this was tenuous. And then I held the phone to their father's ear, and they communicated with their father for about 4 or 5 minutes. And then when I'd every once in a while just lift it up. I didn't want to listen to their conversation. It was not on speaker, but I just lifted up to see if they were still talking. So when I heard there was a lull, that was about after 4 minutes, I just said, okay, we'll let you know how things are going, but we're going to go ahead and do our procedure now, and we'll let you know. And they were crying, and it was really hard. So that was my first experience. And I love to talk about this wonderful nurse that I was working with, a medical ICU nurse, and we were getting ready to prone, and I was helping. And while we're having the phone, she's on one side of the bed and I'm on the other. And we looked at each other through our masks. And something I heard today just made me remember how this was we knew exactly what we were both thinking. This is the most horrific thing that we've ever had to participate in. We're doing our best. We really want to help survival, but we're looking at each other. And the other thing is we're looking at each other. We're like, we can't cry. We can't cry. We have our N95 on. We can't cry. We can't cry. But later we cried after we were out of the room. Mm. So from that, what Rachel, this wonderful nurse, did is she went home and posted on Facebook. And now we have 4 or 5 phones and a couple of iPads, which I now am bringing to IT to have them open up an email account. That's a blocked email. In other words, people can't send an email, but that we'll be able to use technology to actually have phones and an iPad in each one of our COVID units so that we can use that. And that's something I think my hospital would have given that to us as well, but she just went home and got donations. So people are trying to help in any way they can. So we've had an abundance of phones and iPads, and I'll bring them to IT, and IT will enable them and we'll bring them into the unit. But I think everybody should be thinking about, in the absence of actually having an actual human touch, some way to make sure that our families can connect to their loved ones. And I do a lot of family work anyway, and I've been running like a family support group every week for the time that I've been at Grady, which is now 11 years. And reminding ourselves that frequently what families want to do is ask for forgiveness for whatever they perceive they've done. And that can lift their spirit so much. And they also want to say, I love you. And that also, in this dark, horrible, dark hole, this is such an abyss of human suffering and just horror, really. Excuse me. So I think that's something that we can enable that brings some little light to this whole situation. We, at our hospital, if you're calling to ask about a patient, you have to have a code. But in order to get the code, you have to get that from guest services and you have to be in the hospital. So it's been a little difficult for us to figure out who should we be giving information to when they call, because they don't have a family code, which is the way we know that you are allowed to receive information about the patient. So right now we're very, very cautious about that. And typically what we say is, you know, we're so happy to hear from you. We're going to share your good wishes with the person you love, and we're going to have the physician call the number that's listed in the chart so that they can verify that that's somebody that we should be giving information to, because right now we have no way of controlling that.
Barbara,
and as you can imagine, we have to protect also from the media.
Sure. No, I understand. Barbara, how long have you been a nurse?
A very long time.
How long have
I
you?
started at Massachusetts General Hospital in the critical care unit in Mass General in 1975.
And you've
and I don't standardly do pure shift work. I actually try to advance practice and advanced practice initiatives at the bedside for the whole division of critical care. But I do want to say I would never ask someone to go into the room in a way that I thought was not something I would do myself. So that's why I'm in the room a lot. I'm proning patients. I'm working with their CRT. I took care of that first patient because I don't want staff to think I would ask them to do something I'm not willing to do myself. And I'm at risk, basically, because I'm excellent health. I don't think I'm at risk, but by the epidemiologic models, I'm at risk because I'm 68 years old. So I don't mind saying that. I don't care. And I work many, many hours and I travel all over, although not now, of course. But I myself would not train staff on something I'm not willing to do. So I'm very honored and pleased that my hospital facilitates that for me, and that I have a lot of access in many ways, and that I'm asked to come and help. And I am aware that I have that risk factor, but I'm in very good health. So hopefully we'll all be together AC after Corona.
Correct. So you've been at this for more than 4 decades.
Oh my gosh. Yes.
Have you ever seen Have you ever seen anything like this before?
Uh, so I was on the ground in Haiti 18 hours after the earthquake. So yes, I have, but not anything like this before
What do
in
you
the
think?
United States.
What do you think about when you go home at night?
I think about how I wish I could do more. I think about how I really want to keep all my colleagues as safe as possible. I think about how I want to see my first grandchild who's due in a week, how I probably won't be able to hold them for a while and maybe never. But mostly I just think about, I go home and I think about this day and little moments of joy in the day, and then all the moments of sorrow and suffering. Pretty much every night when I go home, I'm married to a very wonderful person who wants to take really great care of me and who tries to make sure that I'm having something to drink and something to eat. And almost, I would say almost every day, I cry. It feels very similar to me, that very first process when I was in Haiti with hundreds of people who were so damaged with no resources and no providers and nothing that we were able to do in the very beginning, very small amounts of things that we could do in the beginning. It feels very much like that. Feels also very similar. I was in one of the first, I actually was there to receive the first bus that came from New Orleans to Houston after Katrina, and just the deluge. So, I mean, there are similarities, which is the deluge of human suffering and sorrow, and not knowing where your family is and not being with your family, and how soul destroying that is, and how harmful and hurtful that is to our own psyche and to the way in which we're used to giving care, which is, this is not normal. This is not the new normal. Anybody who says this is the new normal, this is not the new normal. This is the worst of the worst situations. But in that worstness of the worst situations, there are really wonderful blossoms of kindness. There's a lot of love and support for each other and our communities. Like, people are out on their balcony and clapping, and that's really, you can't believe how much that uplifts us. Or people that are contacting me all the time. Like, I'm getting 30, 40, 50, 60 emails a day. What can we do to help? We want to bring you snacks. We want to bring meals for your staff. We want to bring little cards that our kids have made so you can share them with your staff that are thank you cards. And all those things, which probably seem really small to people, really loom large for us. They are so, so meaningful. So I think that's really important. I don't actually say since February 28th, I would say I haven't really had a good night's sleep. And I don't think I've had a sleep without nightmares, quite honestly.
Well, Barbara, I'm incredibly thankful for you and your colleagues and your peers and all the others who are doing unbelievable, selfless work out there. And I appreciate you sharing this with us, your courage and your transparency. It's very, very powerful.
Thank you. I just want to be sure to say it's not me. It's all the team that I'm working with and all the teams everywhere, that we are here together. We are trying to get through this together. And I'm so grateful to just have the honor of taking care of all of your loved ones and the honor of taking care of each other. I feel like it's an honor, no matter how devastating it is. And I'm one tiny little cog in this big wheel. And I appreciate having the opportunity to share with you, and thank you so much.
My honor as well. Thanks so much. Appreciate it. And stay safe and get some rest.
Thank you.
All right.
Trying. Thank you.
Thank you. This has been Joe Mullings with The Other Side.